This is Dr. Daniels, and we're going to talk about threats to skin and tissue integrity. And if this doesn't give you the heebie-jeebies, I don't know what will. The next couple of slides, I should say. All right, we're going to talk about, with skin disorders, we're going to talk about causes, what makes infants and children different in regards to getting skin disorders, history, subjective, objective, and diagnostics. All right, so what are causes? Injury. So anything that can injure the skin. It could be burns, chemicals, an infection, or even just like getting a splinter. Those are all injury. Anything that injures the skin can cause a skin disorder. Also, any contact with any allergen or irritant. So even certain soaps or detergents can irritate people. Dyes, different types of fabric. Wool is, for example, is very irritant to the skin. There can be things out in the wilderness like poison ivy or poison oak. People have latex allergies that could irritate the skin. Or even like with kids, we talk about like a diaper dermatitis. They get irritants because of the urine and feces that sit against the skin. So anything that, irritates or the skin is allergic to can cause a skin disorder. It can be hereditary. There are many hereditary conditions like eczema, which is very common, especially if you have allergies or asthma, or if your parents have allergies or asthma. There are diseases like systemic lupus erythema that causes that butterfly rash, or EB that causes the blisters. And age. There are certain skin disorders that are just more prevalent in certain age groups. So we talked about earlier infants with diaper rashes. School-age kids tend to get more scrapes and bumps and bruises, right? Because they're active. Teens tend to have more problems with acne. So these are, whether it be injury, contact with an allergen or irritant, hereditary or age, these are all things that can affect our skin and cause different disorders. So what makes kids different? One, their epidermis is loosely bound to their dermis, which basically means they have thin skin. So we have to be very careful with topical medications because we don't know the absorption. So in other words, we don't know how much medicine they are actually getting. So we need to be very careful about using topical meds. They have low sub-Q fat. Or decreased subcutaneous fat. They don't have all the cushioning that we adults do. So they have a more difficult time regulating their temperature. So they're at much higher risk for developing hyper or hypothermia. They blister more easily than we do. They're more susceptible to bacterial infections, especially because they have increased water content in their skin. They often have skin disorders because of systemic symptoms, or they're associated with systemic symptoms. So they'll get a viral exanthem when they get strep throat. That's very common for them. Their sweat glands aren't fully developed, which causes them to have drier skin, and drier skin can lead to more susceptibility to some infections. And they have a high oxygen-rich blood, and that makes their skin appear more red, or rashes might appear more prominent because of that. And in general, kids tend to be affected by eczema more when they're younger. Most cases, I believe it's something like 75% or 80% of cases of eczema are resolved by adulthood. So because of this, kids are just more at risk for having, or it's more common to see kids with different skin disorders. So one of the first things we want to know when we're getting a history and subjectiveness from the patient are going to be so important when diagnosing skin disorders. The evolution. Basically, what happened? Did the rash come first? Did symptoms come first? What symptoms were involved? How has the illness evolved? Basically, How did it evolve? Any previous skin conditions? Has the child had this condition before? Do they just have a different kind of rash? Do they have any hereditary things? Do they have any allergies like asthma that's going to make them more prone to a certain type of skin disorder? The onset of it, was it related to any foods or medications? Did the child try a new food and break out with a rash? Did they start an antibiotic and then develop something? Contact. Did they have contact maybe with another child who has a rash and now that child has the same rash? Did they come into contact with a new detergent or soap or lotion? Were they outside and come into contact with a plant or some kind of insect? Were they in the house and got in contact with some kind of chemical? Do they have any alterations in feelings? Only they can tell you this. Have they lost feeling around the rash? Increased the sensitivity? Decreased the sensitivity? Or maybe have some kind of alteration in their sensitivity? And their symptoms. Are they localized symptoms? Is it just where the rash is? Or is it systemic? Does the symptoms migrate or do they stay constant? Are they intermittent, come and go? Is there anything that aggravates the condition, like sunlight per se? Are they having any other symptoms like pruritus or pain? Or are they saying, does it sting? Does it burn? Is it prickling, itching, warm to touch? So it's really, really important to get a really good history when a patient comes in with a skin disorder. And basically, has the child eaten anything new, come into contact with anything new, and tell me about this rash. Objectively, we'll get vital signs because if it is something systemic, we'll want to see what's going on with the heart rate and blood pressure and everything else. But we're going to do a really good physical exam. Look at the rash or lesion, and is it blanchable? Is it raised? For the rash particular, what is the size of it? How is it distributed throughout the body? What is the arrangement of the rash? Or for the lesion, is it a primary lesion like an actual macular or papular? Or is it secondary from the primary lesion? So they had a macular rash that they scratched, and now they have a secondary lesion because of that. In diagnostics, we can get a CBC and ESR. This can help diagnose if it's an infectious process. We can get a microscope exam. That's where we can scrape the rash and look under the microscope and see what it is. We can do this especially with fungal infections. It will look like spaghetti and meatballs underneath the microscope. We can actually culture the lesion or rash and biopsy it to see what it grows. And we can do allergy testing, especially, like I said, if they have a history of asthma or hay fever, that might be related to it. So now let's look at some skin disorders based by the etiology. So we're going to first look at bacterial infections. And the biggest concerns with bacterial infections is that they can spread really fast. And any break in the skin can cause an infection. So our job is, 1, to prevent the spread of infection, and 2, prevent any complications, especially those who are immunocompromised because they are at higher risk. Oh, you can hear my puppy barking. So the first bacterial skin disorder that we're going to look at is impetigo. So impetigo is caused by either group A beta hemolytic strep or Staph aureus. Both of these organisms live on our skin. They're normal. But they develop because there's some kind of break in the skin, and these organisms look for an opportunity to kind of get in there and infect. So the kid gets a little abrasion, a bug bite, a small little laceration, anything that causes that break in the skin, and these normal bacteria that live in our skin get in there and start an infection. It's just a surface infection, though. and it tends to be spread by close contact or poor hygiene. Clinical manifestations, very classic, those honey-crusted lesions. So they basically get this lesion that they pick, and it becomes crusted, honey-colored, and it's on an ulcerative base. They are very itchy, and this is why it's so contagious, because it's very easily spread. The child has one abrasion on its nose, it scratches, it's underneath the fingernails, and then it gets a bug bite on his leg, and then he scratches that, and he gets, a secondary infection because he's spreading it all around. You can see it on the hands, the face, the neck, the extremities. Both my kids have had it, and it spreads really fast. Diagnostics is clinical manifestations. We rarely do any scrapings or cultures because it's such a classic rash with those honey-crusted lesions that once we see them, we go ahead and start treatment. And treatment includes removing the crust. So they do warm, wet cloth, and you put the warm, wet cloth on until the crust becomes, where you can, take it off. And then we use a topical antibiotic and antibiotic soap. Rarely do we do oral antibiotics. We only do oral antibiotics if it's widespread, like throughout the whole body, and they're having a difficult time controlling it. The big thing with impetigo is prevention, because it is so common in childhood that we just want to teach parents how to prevent this. And we want to keep fingernails short because, like I said, they will scratch and carry the organism underneath their fingernails. And then we want to wash clothes and items in hot water so that it can kill the bacteria. And we want to make sure that kids aren't sharing personal items like towels that will spread it. And I'm sorry you're hearing my puppy because she wants attention right now. The next bacterial skin disorder we're going to talk about is cellulitis. So unlike impetigo, which was more of just like a surface infection, cellulitis is an acute inflammation of actually the dermis and connective tissue. So it's a little bit deeper. Impetigo can lead to cellulitis if it's not treated correctly. Again, it is strep or staph or H. flu. That's what causes cellulitis. Any of these organisms that live on our skin, and maybe we get a puncture mark or a more significant laceration, and these normal organisms get into there and cause the infection. So clinical manifestations, it's a rapid onset, and they have local manifestations. So like you see, the leg is red and warm, very tender to touch, but they also have systemic symptoms like fever, malaise. They might get chills or lymphadenopathy or edema. And we have to be very careful because this can easily lead to sepsis, and the child or the adult can get very, very sick. It's diagnosed, obviously they're going to have a high white blood cell count because it is a systemic disorder. And we can do cultures of both the site and blood cultures because we want to make sure that the organism hasn't gotten into the blood, because if it has, then the person has developed sepsis and is truly sick. Treatment, normally we can treat with oral antibiotics, but if it is really bad, we can do IV antibiotics. And we use moist hot compresses. The big thing is that we use these antibiotics, we use it for the appropriate amount of time, at least 10 days, because if it's not treated, it can lead, like I said, to a severe systemic infection or even like an osteomyelitis or something more severe. And the last bacterial skin disorder we're going to talk about is those of the hair follicles. So it's inflammation of the hair follicle. And the clinical manifestations depends on exactly what it is. It can be a folliculitis, which is like a pimple. It could be a furuncle, which is a boil, or a carbuncle, which is multiple boils. And again, the diagnostics are typically made by the clinical manifestations. And we treat with warm, moist compresses, topical antibiotics. We can do an IND. An IND is an incision and drainage, and it's where they actually cut into if the boil is big and there's pus pockets within, then they'll go ahead and do the incision so that they can drain those pus pockets, because if the pus pocket is allowed to just sit under the skin, it will continue to eat away at healthy tissue, and the pus pocket will get bigger and bigger and bigger. But if we can open it up and drain that pus pocket so that it can be treated with the appropriate medications, then it won't spread or get any bigger. However, we want to teach families that they should never squeeze it. What happens when you squeeze like a pimple is that most of the time you actually push the pus back down. Rarely do people get like underneath and able to get that pus out without pushing stuff down. So we tell them, please do not squeeze. And also to avoid any poorly chlorinated pools or spas. The rule of thumb is basically if you can't smell the chlorine, then there isn't enough of it in there. All right, fungal skin infections. So fungal skin infections are basically, it's ringworm, what everyone knows is ringworm, but it's not, there's no worms actually involved, so no one get freaked out, although these pictures are kind of, but it's I'm going to mess up saying this, dermophytosis that lives on the skin. So it's this fungal infection that lives on the skin, not in the skin, and it has a raised ring pattern, and that's where the term ringworm comes in. And it's designated by the word tinea, which means fungal, and the area of the body that's affected. So as you see in this first picture, it's tinea corpus, which is of the skin, the trunk, the limbs, the face. You can have tinea curis, which is of the groin area, tinea pedis, which is of the foot, or tinea capitis of the head. The etiology, it's either spread from person to person or from an infected animal to person. A lot of times we see this like even because you'll have infected animals out, in the wild, and they often go around playgrounds that kids play in, and the mulch, like kids that play in the mulch of playgrounds, oftentimes kids get this infection from there. It's very common and can affect, any age group. So diagnostics, oftentimes it's diagnosed just by the clinical manifestations. I mean, you look at it and you know that is ringworm, but we can do a microscopic exam of the scrapings to verify that it is that. Clinical manifestations, it's typically a round, oval, erythematous, scaly patch. So it is raised and scaly, and it spreads peripherally and clears centrally. And what that means is you can kind of see in this first picture of the tinea corpus, you see how it's kind of whitish or more clear in the middle and redder, more erythematous and raised on the outside. So it kind of grows from the inside out. It kind of works its way. So it spreads outward peripherally and clears, meaning the inside will be less raised and less scaly than the outside of the infection. Treatment for tinea corpus and tinea capitis, the treatment is definitely an oral antifungal. This is most likely griseofulvin. and it's treated for a long time. It says 8 to 12 weeks, but I've seen kids on it for much, much longer. The big thing is this is a pretty whammy of a medicine, and it doesn't taste great. Thankfully, we have to give it with fatty foods, so we can give it with things like peanut butter, whole milk, ice cream, so kids don't typically mind having to take those yummy things. But it doesn't taste great. Kids have to get lab work frequently because of liver. It can affect the liver, so they have to get liver function tests before the medicine and periodically while taking the medicine. And again, like I said, why they say treatment is 8 to 12 weeks, it could take months and months in order to get treatment, full treatment. And sadly, especially with like tinea capitis, even after treatment is done, it may take 6 to 12 months for the hair to regrow in that area. And in some cases, very rarely, but it happens in some cases, that hair may never regrow. So there has got to be a lot of education and a lot of support for these families. Follow up with them, make sure that they're getting the support that they need. Because although it's not really anything bad for the child per se, it is just I don't know what the better word is for annoying or whatever, but it's emotionally draining on them. With tinea corpus, we can also do things like making sure we're wearing loose-fitting garments. We want to stay dry. And the more moisture we have, the worse the infection's going to get. That's the same thing for tinea curis. You want to keep that groin area clean. Tinea curis is like what we call jock itch. And it's typically seen only in adolescents. You'll rarely see it. I don't think it can happen in kids. You have to be older to, those sweat glands develop down there and it gets moist and yucky. And then tinea pedis, we want to keep the feet clean and dry. It's the athlete's foot that you see, so making sure that, there's powders and creams out there if it's a mild case that you can use. And then head lice. Ooh, everyone's going to start itching their heads now. I know I do. So these are your parasite skin disorders, head lice. And it's basically an infestation of the scalp by a parasite, Pediococcus humanus capitis. And on the left there, you can see that's what the adult lice looks like. It's actual bug. And you can see kind of the cycle up here that it lays 5 to 6 nits a day. So the nits are the eggs. So 5 to 6 a day, and then those kind of hatch in 7 to 10 days and become nymphs, and they reach adulthood in about 8 to 10 days. And so now those 5 or 6 adults are laying 5 or 6 more, and it just kind of cycles and cycles and cycles until you look like this and you're just completely infested. All these little white dots that look like little grains of rice, those are the nits. So the clinical manifestation, you'll see those little nits and you'll see those adult or nymphs. And let me tell you, it is, both my kids have had it. They each had it at separate times. My daughter got it 1 year, and my son got it about a year later. I can remember sitting on the couch with my son, and he was sitting in my lap with his head up against my chest, and I was just playing with his hair, and I saw this bug crawl through, and I was like, oh my God. And I jumped up, and I threw him off me, and I threw him outside. And the poor thing was so upset. And then I was trying to make it like it was no big deal. But it just, you just start itching. And it has nothing to do with hygiene or cleanliness or anything like that. And it does have a lot of stigma. So we do have to be careful. But it does feel kind of whatever. So most of the time, the only symptom the child will have is itchiness. You'll see them itching. typically at the occipital area, behind the ears, at the nape of the neck. We won't see this a lot in African Americans just because the adult or the nymph, it can't really grab onto the shaft of the hair of the African American hair, so we don't see that a lot. Treatment, they say application of basically whatever kills the bug. You can't kill the nits. You can only kill the lice itself. So that's not helpful, because if you do a treatment, well, I mean, I guess it's somewhat helpful. You do a treatment and you kill all the live bugs, that's great. But then in 5 to 6 days, all these nits are going to hatch, and you're going to have a bunch of new bugs that aren't going to be affected by your treatment you did 5 or 6 days ago. So it is so tedious, and like I said, I've done it twice. You need to remove with a comb and just manually go through the hair and remove all the nits. So they have specialty combs out there, and they're just really, tight combs that kind of catch those nits, because the nits are actually like attached to the hair follicle, like right at the base of the scalp. So you really have to get close and use those special combs that will actually pull the nit off of that. And really, that is the best way to treat lice, because again, when you use the medications, the topical shampoo medications that wash the hair, they will only kill the nymph or the adult. Other ways when we treat, anything that can be washed should be washed in hot water. Anything that can't be washed needs to go into a garbage bag and tied up for 2 weeks. Both times we had lice, it looked like homeless people lived in my house, because we had garbage bags just sitting around everywhere because stuffed animals and all those different things. So you really, prevention is key. We don't share things like brushes and combs, and remember, the adult has to live off of the nutrients it gets from us. So they won't live long off our body. But if they are on a piece of hair that comes off our scalp, and then that hair is in a comb, and then my friend uses my comb and my hair now gets put on their hair, that's how it gets transferred. So we don't want to use barrettes, rubber bands, hats, hooded jackets, anything that could potentially transfer a hair from one person to another. You can't really get it just by touching the same couch as somebody else touched, unless you really rub and got that piece of hair on you. But anything that, touches hair, and so it's spread very easily. So that's why, again, there's a big stigma that it's about hygiene and whatnot, but most of the time people don't even know they have lice until they have, like I said, my son had it, and God knows how long he had it. Thankfully, with both my kids, I caught them early enough. You'll see if there's a kid in school that has it, the letter goes home and everybody gets told about it. So, but just good education is key. All right, and then there are viral skin disorders. Some of the viral skin disorders are warts, which is caused by HPV. Their course is very unpredictable, and most of the time they resolve on their own. Parents don't like the look of warts, so they often want treatments, and they try different things like freezing them off and such, but honestly, they will resolve spontaneously. Herpes zoster, which is shingles, that has to be, you get that if you have had a previous exposure to like chickenpox or have had the vaccine. It's typically later on in life and not in childhood. There's herpes simplex, and there is type 1 and type 2. Type 1 is the cold sore, so any of those sores around the mouth. And type 2 is actually, when people think, oh, that person has herpes, those are the genital sores. So let's look at chickenpox since we're talking about viral infections. That baby looks really happy, which I feel like is very misleading because this is what most little babies look like that have chickenpox. They are pathetic because they just don't feel good. And it's caused by the varicella zoster virus. In clinical manifestations for chickenpox, they have that characteristic rash. So what happens is they get a macular that develops into a vesicle that then crust over. So what you'll see is that these kids will have different types of lesions at the same time. And it starts at the trunk and spreads outward. So as the disease progresses, you'll see more crusted lesions on the trunk. And then as you move out, then you'll see vesicles and then you'll see macular. So the trunk will heal first and then the head and extremities will. So it is very, very itchy, which again is why it spreads so easily. And the kids they do have some systemic symptoms. They'll get a slight fever and feel malaise. They don't feel good. We have to be very careful because the incubation period is 2 to 3 weeks, and the child is contagious from the day before the lesions erupt until 6 days after crust forms. So vaccines were made for this. We're going to talk about vaccines in just a minute because this can be a fatal disease for those who are immunocompromised. Treatment, the child needs to be on droplet or contact isolation. We need good skin care. We need to prevent any, like we said, secondary lesions or rashes because of the itchiness. So we give them things like Benadryl, the calamine lotions, antihistamines, anything to kind of help, limit the itchiness and help them avoid scratching. Keeping those nails really short. Sometimes we have to put mittens or socks over their hands so that they rub and they don't itch. And we make sure we aren't giving any aspirin. Complications, cellulitis because of itching. So if they itch, again, remember that cellulitis is because there's a break in the skin and normal bacteria on our skin take that opportunity. So if they could develop a cellulitis, which could lead to a sepsis because their immune system is already down. And they can also develop encephalitis. So, people think chickenpox is pretty benign, but kids get really sick from chickenpox, and we have deaths from chickenpox, which is why we've developed vaccines for it. All right, so talking about communicable diseases. So we have disease rates. They've declined since we have introduced immunizations. And serious complications have been reduced because we have things like antibiotics and antitoxins. So our big goal with communicable diseases is that we want to prevent the spread and prevent complications. So these are your communicable diseases. There is a chart. If you go under course content in the course and under resources, I believe, under exam 2 resources, you will see that there's a communicable diseases chart. This is testable material on these diseases. So measles, mumps, rubella, chickenpox, polio, all of this, you will need to make sure that you know the items in that chart. All right, so when we talk about communicable diseases, we need to understand our terminology. Again, know your chart. So prodromal symptoms are the first symptoms before the rash appear. So let's say we're talking about chickenpox. The child will present with maybe a little fever, a little headache, maybe even a little tummy ache, but no rash yet. So we don't really know what's going on. We're like, oh, the kid has some kind of virus. Then they get the constitutional symptoms. And the constitutional symptoms are the classic signs and symptoms of the disease. So again, for chickenpox, we would see those classic lesions where they have lesions of various degrees, some macules, some vesicles, some crusted over. We have those classic signs and symptoms. The incubation period is the interval between exposure to the infection and appearance of the first symptom. And we don't always know that when we get exposed to somebody. Because, like I said, with the prodromal symptoms, this kid has chickenpox, and like we said, with chickenpox, you are technically contagious from the day before the lesions erupt. So if the child goes to school and maybe they just have a little headache or tummy ache, and the parents send them to school because they're like, oh, maybe they ate something, maybe they're tired, but they have chickenpox, they're really contagious at that point, that day before those lesions erupted, and then the next day the lesions erupt. So the incubation period is then all those kids that got exposed to that kid from that day, and for chickenpox, since the incubation period is 2 to 3 weeks, in 2 to 3 weeks, we may now see an outbreak of chickenpox at that preschool because that kid exposed all those other children before they knew they had it. It's not done maliciously or on purpose, but that's what happens a lot of times. And then the period of communicability is when it's contagious. So for chickenpox, it's contagious from a week or two before the outbreak until the lesions are crusted over. So those are your terminology, knowing, about your communicable disease. Then we're going to talk about history. And again, we kind of already talked about this when we talked about skin disorders in general. Has the child had any recent exposure to anyone with that communicable disease or similar, symptoms? What is the child's immunization history or history of having disease? Because that's going to help us rule out or limit our field. If we know that the child's been immunized against chickenpox or has had chickenpox before, then the likelihood of them getting it again is lower. Or if they've been immunized against it, the likelihood of them having that disease is low. And that helps us rule some things out. It doesn't totally exclude it, but it helps limit it. On physical exam, we're going to look at the rash, the lesion, the inflammation, and then there's different terminology. Exanthem is rash that's on the skin with inflammation, but not in the mucous membranes. And then enanthem is a rash on the mucous membranes. Or a catarrh is an inflammation of the mucous membranes, especially the head and throat. So these are different ways to, describe the rash and lesion where it is. And again, all of these things help define communicable diseases, because as you study those charts, you'll understand that chickenpox, has these prodromal symptoms and these constitutional symptoms, and this is the incubation period, and this is where they're contagious, and on physical exam, this is the type of rash they have, and it's all very, classic. So, and that's why we can diagnose these. So those are what the things you're going to need to know on that chart. Management, there's standards of care for management of each of the disease processes. So these are management. What we're going to talk about now is just kind of the management in general. But for measles, mumps, rubella, chickenpox, polio, Fifth's disease, DTaP, all of those have, some specific managements too, in addition to this general management. So again, that's something you're going to know when you study that chart. And that's not something I can really lecture on. That's just pure memorization. So that's a good one to make flashcards with and get to know. So for a lot of them, we isolate them. Actually, until we really know what it is, we go ahead and isolate. It's always better to isolate first and rule out. Oh, my puppy's back. You're going to hear her jingle. Supportive care. We can do things like treating any signs and symptoms. We want to minimize any discomfort, provide emotional support, prevent complications. So one, we need to identify those at risk. We've talked about things like cutting the fingernails, antihistamines for itching, oatmeal baths maybe to soothe skin. We're going to prevent the spread. And we're going to talk about prevention education, which is immunizations, which is what we're going to talk about now. So here is a communicable disease. It's not a crossword, is it? Puzzle. And here is the questions for it. Try to do it for yourself, really. See, because when you do your flashcard, see if you can do this. I mean, obviously, here's the answers, but I would recommend that you try to do it yourself. It will show you what you know and what you don't. Okay, so we're going to talk lastly about immunity. So that's your last little diagram. So the two main types of immunity are passive. And passive is when a person's body doesn't have to do anything to mount the immune response. So it's either passive, it's either natural, and that's when like we get antibodies from mom, like through breastfeeding, or it's passive acquired. And that's when we get like an immunoglobulin, like a toxoid. And that's how we get exposed to the antibodies. Or immunity could be active. And active, it lasts longer. So unlike passive, which typically tends to be short-lived, only lasts for a few months, when we get active immunity, it can last a long time, sometimes a lifetime. And this is because the person's body actually mounts an immune response against the antigen that they are exposed to, and they develop the antibodies. And again, it could be natural, where they actually are exposed to the disease, so they mount that immune response, or it can be acquired, like when we give vaccines. So what are vaccines? Vaccines are made from the antigens from the disease. And when we give those antigens from the vaccine, the body recognizes it. So we give the antigens for measles. We give the antigens for mumps. We give the antigens for varicella. And the body says, oh, we have that disease. We have measles. We have mumps. We have chickenpox. And it mounts an immune response and develops the antibodies. So then when the child is out in the community and gets exposed to chickenpox, the body says, oh, we already have the antibodies for that. So we mount the immune response and we prevent the child from actually getting the disease. And the reason we want to vaccinate children and have them not get the disease is because children die from these common diseases. It's really sad. They get really sick. And we've talked about all the things that make them special and different and how their immune system is just not up to par and they're more susceptible. And they get really sick and die from something like chickenpox, die from something like measles, polio. They'll develop deformities that they don't need to develop. So we can prevent them from getting sick because we give them, an antigen, and that can be a live antigen or a dead antigen. So the only time we really need to be careful is with live vaccines we don't give to those who are immunocompromised. But we give them the antigen, the body develops, an immune response and develops the antibodies. And then anytime the child is there, then exposed in the future, those antibodies are there to protect the child from developing the actual disease. Or if they do develop the disease, they develop a less severe case of the disease. And what's great is that there are kids that cannot get vaccines. There are kids with cancer that can't get vaccines. There are kids that have certain immune disorders that can't get vaccines. And so by, having the community be protected, we are in turn protecting those who can't get it. So we don't want everyone out there with chickenpox, exposing those who are immunocompromised, because for those who are immunocompromised, that's the ones that are, most at risk, most deadly. And we can pull titers to see immunity. So basically, we can get blood work and we can see how high our titers are, basically see how many antibodies we have to a particular disease process. And if the titers aren't high enough, then we can revaccinate as necessary. So when we talk about vaccinations, we're going to talk about administration. We want to make sure that it's properly stored. Again, we protect it against light. When we give it, we need to make sure that we make it as less hurtful as possible, although any person that gets a shot is going to tell you it hurts. We rotate sites. There are precautions. We make sure they don't have any allergies to eggs, see if they've had any previous reactions. We make sure that we're doing teaching, and we document and monitor. VAERS is the Vaccine Adverse Event Reporting System. So everything is reported. So even if it's something small like, a rash, we go ahead and report that because we may notice that a certain batch of vaccines that a bunch of kids are getting a rash. So they'll pull that because, maybe that one has, too strong of antigens or whatever. And then the VIS is the vaccine info sheet. And this is given to all parents before the vaccines are given. And it's, if you have kids, you know exactly what I'm talking about. It's that sheet that nobody really ever reads as parents, but they should, because it talks about what things to look for, what's normal, what's not normal, who to call, when to call, all those type of things. And then contraindications. There are very few total contraindications to giving vaccines. Parents will say things like, well, they were really tender at the site, or it was red, or it got swollen, or they got a little fever, or they acted funny for a little bit afterwards, or, my baby's premature, so they shouldn't get it, or they were sick a week ago and shouldn't get it because their immune system's already fighting so much. And that's honestly all malarkey. None of those are true contraindications. The only true contraindications is if the child has anaphylactic shock, has a history of seizures, or history of high fever with getting vaccines in the past. Otherwise, there's not really anything that stops them from getting their vaccines. And that's it. All right. So again, don't forget to go into the course and get the communicable diseases worksheet that has, like I said, measles, mumps, rubella, all of that on it, and study that along with this for your skin and tissue lecture. Have a great day.